Discussion on peripheral signs of aortic regurgitation. Color Doppler echocardiogram in aortic regurgitation. Left panel shows the Doppler tracing from the left ventricular outflow tract with the tongue-shaped upward AR jet and the conical downward jet of flow in the LVOT. Right panel from the apical 5-chamber view shows the mosaic AR jet from the aortic valve into the LVOT and well into the left ventricular cavity. The continuous wave Doppler cursor can be seen across the LVOT. Peripheral signs of AR are mostly due to the high stroke volume and high pulse pressure. They are noted in severe AR. These are features of aortic runoff and can occur in other situations of aortic runoff like ruptured sinus of Valsalva into right atrium. Arterial pulsations in the retina. Normally there are only venous pulsations visible on the ocular fundus. In aortic regurgitation, retinal arterial pulsations are visible. This is known as Becker's sign. Muller's sign, systolic pulsations of the uvula in aortic regurgitation. Dancing carotids, prominent carotid pulsations due to the wide pulse pressure in aortic regurgitation. De Musset's sign, head nodding sign in aortic regurgitation. Bispherians pulse is more suggestive of free aortic regurgitation than a combination of aortic stenosis and regurgitation. Bispherians pulse has two peaks in each systole. Locomotor brachii is a prominent pulsation of brachial artery seen in aortic regurgitation. It can also be seen in elderly individuals without aortic regurgitation. Collapsing pulse or water hammer pulse is noted in the radial artery with upper limb lifted up passively and felt by the palm of the hand. Water hammer was a toy in the Victorian era in which fall of water in a vacuum tube produced a characteristic feel. Quincke's sign, prominent nail bed capillary pulsations. Duro's murmur sign, a stethoscope kept over the femoral artery picks up a systolic murmur with proximal compression and diastolic murmur with distal compression. The diastolic murmur is more specific. Pistol shot sounds can be heard over the femoral arteries and sometimes over the brachial arteries. Gerhardt's sign, hepatic pulsations in severe aortic regurgitation. Rosenbach's sign, splenic pulsations in severe aortic regurgitation. Main's sign, exaggerated decrease in diastolic blood pressure more than 15 mm of mercury on raising the upper limb. But the validity has been questioned as this can be noted in younger age without aortic regurgitation. Lincoln's sign, prominent popliteal artery pulsations. Sherman's sign, prominent dorsalis pedis artery pulsations. Hill's sign is based on the difference between the upper limb and lower limb arterial pressures recorded by the sphygmomanometer. Systolic pressure recorded from the lower limb is more than that of the upper limb. Difference in systolic pressure above 20 mm of mercury is taken as significant. When Hill's sign is taken for grading the severity of aortic regurgitation, the following classification is usually applied. Mild AR 20 to 40 mm of mercury, moderate AR 40 to 60 mm of mercury, severe AR more than 60 mm of mercury. It may be noted that direct intra-arterial recordings of axillary and femoral arterial pressures did not demonstrate any exaggerated difference in systolic pressures between them. Authors of the study suggested that Hill's sign is an artifact of sphygmomanometric lower limb pressure measurement and has no physiological basis. Cardio-angle vascular index, originally used to measure arteriosclerosis, has been used to assess AR objectively. CAVI measurement includes pulse pressure, difference between upper limb and lower limb pressures, angle brachial index, ejection time, and upstroke time. Calculation of CAVI uses a complex formula. Shiraisi and associates concluded that CAVI parameters could be useful in screening and serial follow-up of patients with aortic regurgitation. This study also documented that Hill's sign correlated with severity of AR. Angle brachial index increased in aortic regurgitation. Hill's sign or difference between upper limb and lower limb pressures correlated semi-quantitatively with severity of AR. Here is all about alternans: Traube's pulse, total pulsus alternans, diastolic pulsus alternans, right ventricular pulsus alternans, biventricular pulsus alternans, and electrical alternans. Pulsus alternans or Traube's pulse was described by Ludwig Traube in 1872. Pulsus alternans is nothing but alternating pulses having different volumes and is a feature of left ventricular dysfunction. It is well known that pulsus alternans can be augmented by a premature ventricular contraction. A rare case of pulsus alternans due to 2:1 left bundle branch block has also been described. The patient had normal coronaries and left ventricular ejection fraction of 50%. Dyssynchrony associated with LBBB was thought to reduce left ventricular output during block and consequent lower pulse volume in alternating beats. Pulsus alternans with diastolic left ventricular dysfunction in the absence of systolic dysfunction was noted in a case of renal artery stenosis and pulmonary edema. The pulsus alternans in this case disappeared after renal revascularization. Treatment of heart failure causes improvement in pulsus alternans. Similarly, improvement in pulsus alternans by ventilator therapy has been documented. First set of references for pulsus alternans. Second set of references for pulsus alternans. Total pulsus alternans or pulsus alternans totalis occurs when the force of contraction is so low in alternating beats that aortic valve fails to open. It can be documented by simultaneous pulse and ECG recording. In an interesting case report, ECG monitor showed a rate of 160 per minute due to atrial tachycardia, while simultaneous pulse tracing showed a pulse rate of 80 per minute. There was tachycardiomyopathy due to incessant tachycardia producing left ventricular dysfunction. Pulsus alternans was abolished after successful radiofrequency catheter ablation of the atrial tachycardia. Reference for pulsus alternans totalis. Though there is no pulse felt in diastole, diastolic pulsus alternans has been described as the alternation of mitral inflow velocities. In one case, it was due to dilated cardiomyopathy and pulmonary embolism. Another report was in severe heart failure. Alternation in ventricular diastolic function can be documented both by Doppler echo and tissue Doppler imaging. Earlier description of diastolic pulsus alternans was alternation in left ventricular diastolic pressures as in case of hypertrophic cardiomyopathy. First set of references on diastolic pulsus alternans. Second set of references on diastolic pulsus alternans. Right ventricular pulsus alternans can be isolated or associated with left ventricular pulsus alternans. Right ventricular and pulmonary artery pulsus alternans are demonstrated by cardiac catheterization studies. In one case of right ventricular pulsus alternans, due to right ventricular infarction, improvement was obtained by coronary sinus pacing. Doppler alternans and murmur alternans corresponding to right ventricular pulsus alternans has been noted in critical pulmonary stenosis with right ventricular dysfunction. Pulmonary embolism and pulmonary hypertension are other situations in which right-sided pulsus alternans can be observed. A rare occurrence of right-sided pulsus alternans was in a case of prosthetic mitral valve thrombosis. In another interesting case of right ventricular pulsus alternans in left ventricular diastolic dysfunction, pulsus alternans was demonstrated in right ventricle pulmonary artery and pulmonary artery wedge positions, but not in the left ventricle or aorta. Here are the first set of references on RV pulsus alternans. Second set of references on RV pulsus alternans. Pulsus alternans is alternating volume of pulse with a regular rhythm mostly seen in left ventricular dysfunction. Biventricular and right ventricular pulsus alternans needs cardiac catheterization or Doppler echocardiography to demonstrate the alternating right ventricular or pulmonary artery systolic pressures. Biventricular pulsus alternans is much rarer than left ventricular pulsus alternans. One case reported was biventricular pulsus alternans due to anterior myocardial infarction. Another report was a demonstration of biventricular pulsus alternans by echocardiography in a case of pulmonary embolism. A combination of dilated cardiomyopathy and pulmonary embolism was responsible for biventricular pulsus alternans in another case. Demonstration of alternans was the alternating LV and RV outflow velocities. Diastolic alternans was also described in inflow velocities, though strictly the term diastolic pulsus alternans is not ideal because there is no pulse in diastole. References for biventricular pulsus alternans. Electrical alternance is a phenomenon seen on ECG with alternation in amplitude of QRS complexes. The term electrical alternance totalis is used when the amplitudes of all the waves P, QRS and T show alternating amplitude. Electrical alternance totalis is seen in cardiac tamponade and is thought to be due to the swinging movement of the heart within the pericardial cavity. Electrical alternance may sometimes be associated with its mechanical counterpart, pulsus alternans. Isolated alternance of the ST segment and T wave may also occur. T wave alternance can be macroscopic or microvolt T wave alternance, which can be detected only with special equipment. ST segment and T wave alternance have been reported in vasospastic angina and is thought to be the harbinger of life-threatening arrhythmias. T wave alternance, both macroscopic and microvolt, have also been linked with ventricular arrhythmias and sudden cardiac death. T wave alternance has been noted in congenital long QT syndrome preceding torsades dispendis. Discussion on causes of elevated prosthetic valve gradients. Elevated gradients across prosthetic valves can occur due to various reasons. But before declaring that prosthetic valve gradients are elevated, the usual gradient across the given type of prosthetic valve should be known. Different types of normally functioning prosthetic heart valves have different gradients. Normal gradient is different between the various valve positions. Transmitral prosthetic valve gradient is lower than transaortic prosthetic valve gradient. If the gradient during postoperative review is available, it can be used as a benchmark for comparison. Some of the important causes for elevated prosthetic valve gradients are prosthetic valve thrombus, pannus, large vegetations, calcific degeneration of bioprosthetic valve, patient prosthesis mismatch, high output state, pressure recovery phenomenon, and high velocity central flow in a bileaflet valve. Clinical scenario should be considered in detail during evaluation of elevated gradients, as echocardiographic patterns have their own limitations in the assessment of prosthetic valves. Body surface area should be checked while assessing patient prosthesis mismatch. Elevated transprosthetic gradient is an important feature of thrombus within the prosthetic valve. In the mitral position, a gradient more than 8 mm of mercury is suggestive of prosthetic valve thrombosis. In case of aortic prosthetic valve, the suggested cutoff value is more than 45 mm of mercury. A word of caution is needed here in that gradients may be low in low output state despite significant obstruction. This has been called silent Doppler prosthetic valve thrombosis. Pannus formation or tissue growth into the prosthetic valve can increase the transvalvular gradients. An in vitro study has shown that when the pannus width was 25% of the valve diameter, gradient can be increased more than 2.5 times than without pannus. Large vegetation has been mentioned as a very rare cause of prosthetic valve obstruction. Large vegetations are a feature of fungal endocarditis and staphylococcal endocarditis. Calcific degeneration can occur in glutaraldehyde preserved bioprosthetic valves. This is yet another cause of increased transprosthetic valvular gradient. Patient prosthesis mismatch is important mostly in the case of aortic valve. When the aortic valve is replaced for aortic stenosis, aorta may be small and may take only a relatively smaller prosthesis. Aortic root widening procedures are done sometimes but can increase the surgical risk. Patient prosthesis mismatch can be assessed by checking the body surface area and the corresponding size of the prosthetic valve. Severe patient prosthesis mismatch is defined as indexed effective orifice area less than 0.65 square centimeter per square meter body surface area. As we have seen low gradient with low output state, higher gradient can occur in high output state. This aspect should be considered before considering an elevated prosthetic valve gradient as being due to obstruction of the valve. Pressure recovery phenomenon can impact the Doppler assessment of prosthetic valve performance. Pressure recovery phenomenon is recovery of aortic pressure beyond the region of the jet across the aortic valve. The lower pressure near the valve is due to the effect of the jet, which causes a reduction in the lateral pressure. To get the recovered pressure or settled pressure, catheter has to be pulled back about 2 to 3 cm beyond the sinotubular junction. The lower pressure near the valve gives a falsely elevated transaortic valvular gradient when measured by Doppler echocardiography. High velocity jet through a relatively narrower central orifice of a bileaflet prosthetic valve can produce a falsely elevated gradient. This was noted on catheter pullback through the central orifice, while it was not there on pullback through the side orifices. The mean difference between the central and side orifices was 46%. This value corresponded to the elevation in Doppler gradient. It was an in vitro study in an aortic valve pulsatile model. Tissue Doppler imaging measures the velocity of myocardial motion using Doppler principles. The usual Doppler echocardiography measures the velocity of blood flow using the Doppler signals from the fast-moving blood cells, which are of low amplitude. Tissue Doppler measures low velocity, high amplitude signals from myocardial motion. Tissue Doppler is not able to differentiate between passive motion and active motion due to fiber shortening, but strain imaging is able to do so. Color-coded tissue Doppler imaging is sometimes called color kinesis. Pulsed wave TDI is useful to measure myocardial velocities in the long axis as the movement is parallel to the Doppler beam. Mitral annular TDI has three waves: SA systolic myocardial velocity, EA early diastolic myocardial velocity, and AA myocardial velocity during atrial contraction. While imaging from the apical view, systolic velocities are positive and diastolic velocities are negative. Systolic velocity at the lateral mitral annulus correlates with the longitudinal systolic function of the left ventricle. Diastolic velocities depend on ventricular diastolic function. TDI assessment of diastolic function is load independent compared to the conventional measurement using mitral inflow velocities, which are highly sensitive to preload. Tissue Doppler imaging at the level of the mitral annulus septal side illustrating EA and AA. EA is also called E prime to differentiate from mitral inflow velocity. A in EA stands for annulus. EM is used to indicate myocardial. E by E prime measurement is used to assess diastolic function by tissue Doppler. Method may vary in technical details between machines. In low-level machines, we have to measure both E from mitral flow Doppler and E prime from tissue Doppler at the septal mitral annulus level and calculate the ratio manually. In other machines, as illustrated in this image, E is measured initially and stored. After that, E prime is measured and the machine automatically calculates the E by E prime ratio marked by green arrow at the top left corner in this image. The high E by E prime ratio in this case indicates left ventricular diastolic dysfunction. E by E prime at lateral mitral annulus more than 10 and E by E prime more than 15 at the septal mitral annulus indicates left ventricular diastolic dysfunction. E by E prime values less than 8 would indicate normal left ventricular diastolic function. The yellow tracing is pulsed wave tissue Doppler imaging. First negative wave is the mitral E prime. The next negative wave after E prime occurs during atrial contraction and is designated AA. The positive wave after AA is the SA wave, representing the systolic myocardial wave recorded as the annulus descends towards the apex. SA at the lateral mitral annulus is a measure of the longitudinal systolic function and correlates with left ventricular ejection fraction. Septal E prime is slightly lower than lateral E prime. Measurement of E prime is useful in differentiation of pseudo-normalization in the mitral inflow from the normal pattern. Negoye and associates studied 35 patients with hypertrophic cardiomyopathy by simultaneous cardiac catheterization and echocardiography. They concluded that LV filling pressures can be estimated with fair accuracy in patients with HCM by measuring E by EA. Changes in LV filling pressures can also be tracked by changes in the ratio. Stress tissue Doppler imaging or stress echo with tissue Doppler. An important limitation with stress tissue Doppler imaging is the technical challenge of acquiring both two-dimensional and tissue Doppler echocardiographic information during exercise. Peak myocardial systolic velocity SA increases with both exercise and dobutamine stress. Tissue Doppler techniques can identify abnormal segments in a better way than two-dimensional echo and has a better reproducibility than it. Peak velocities 5.5 cm per second or less can identify abnormal segments with a sensitivity of 96% and specificity of 81%. Tissue Doppler derived atrial conduction time. Total atrial conduction time denotes the total period required for atrial activation. Conventionally, it is measured using signal average electrocardiogram as the maximal P wave duration. It has been shown to be a powerful predictor of atrial fibrillation. A simpler method which can be done in any echo lab without the use of signal averaged ECG is a tissue Doppler and surface ECG combined measurement of atrial activation. PA-TDI is measured from the onset of P wave on the surface ECG to the tissue Doppler derived PK wave at the lateral left atrial wall. PA-TDI has been shown to predict new onset atrial fibrillation, recurrence of AF after catheter ablation, AF after acute myocardial infarction, and even AF after cardiac surgery. Cardiac surgeries in which PA-TDI has been successfully used to predict AF include coronary artery bypass grafting, aortic valve replacement for aortic stenosis, and surgery for mitral regurgitation. In mitral regurgitation, prediction of AF is very important as the left atrium is very large. Onset of AF after relief of mitral regurgitation jet, which had a cleansing action on the left atrium, may lead to thrombus formation and increase the risk of stroke and other systemic embolism. U wave on ECG occurs after the T wave and is usually seen in the mid-precordial leads. In hypokalemia, T waves become flattened and U waves become prominent, or apparently so because of near absence of T waves. Important conditions associated with U waves are systemic hypertension, aortic and mitral regurgitation, and coronary artery disease. One theory about the genesis of U wave is that it is due to repolarization of the Purkinje fibers. Another possibility is that it is due to after potentials caused by mechanical forces in the ventricular wall. A third hypothesis suggests that it is due to prolonged repolarization of the mid-myocardial M cells. Yet another hypothesis is the delayed repolarization of papillary muscles. None of these theories have been widely accepted. An inverted U wave usually has the same significance as inverted T wave. A negative U wave is considered to be highly specific for heart disease and is associated with Other abnormal findings on ECG in 90% of cases. Discordant U wave inversion with upright T is also thought to represent myocardial ischemia. An interesting case of U wave due to compression of right ventricle by a reconstructed stomach tube after surgery for esophageal cancer has been reported. Persistent giant U wave inversion was noted in a case after anoxic brain injury. It may be noted that giant T wave inversion can also be seen in brain disorders. Exercise-induced U wave inversion in anterior leads has been associated with stenosis of proximal left anterior descending coronary artery in multiple case reports. U wave alternans along with pulsus alternans has been described in left ventricular failure. Alirocumab is a new medication for the treatment of dyslipidemia. Alirocumab is a human monoclonal antibody to PCSK9. It is used to treat high cholesterol which is not controlled by diet and statin therapy. Those with statin intolerance will also benefit from this drug. Several patients treated with currently available oral lipid-lowering agents do not reach target low-density lipoprotein cholesterol levels recommended by clinical guidelines. The cardiovascular risk of these patients remain significantly high. Earlier, these patients had only one option, LDL apheresis. Now there is an additional option, PCSK9 inhibitors. Currently available PCSK9 inhibitors must be given parenterally. Function of PCSK9 is to bind to LDL receptors on hepatocytes and promote their degradation in endosomes and lysosomes. The reduction of LDL receptors lead to increase in levels of LDL cholesterol. Inhibition of PCSK9 by drugs like Alirocumab can produce marked reduction of LDL cholesterol levels. Indication for Alirocumab: those with high cardiovascular risk from atherosclerotic disease or heterozygous familial hypercholesterolemia and unable to reach target LDL-C levels with maximally tolerated doses of statins alone or in combination with other lipid-lowering agents. The medication is available as pre-filled syringes or pens containing 75 mg or 150 mg to be given once in 2 weeks as subcutaneous injections. The drug must be stored in a refrigerator. Injections of 75 mg given once in 2 weeks produced 44.2% reduction of LDL cholesterol at the 8th week. The reduction was sustained at 96th week with 47.9% reduction. In addition to LDL, Alirocumab reduced levels of lipoprotein (a) and ApoB. Lipoprotein (a) is an independent risk factor for cardiovascular disease. Statins have hardly any effect on lowering lipoprotein (a). Lipoprotein (a) possibly accounts for the residual cardiovascular risk after reaching target levels of LDL cholesterol. A meta-analysis of 24 randomized controlled trials totaling over 10,000 patients showed 50% reduction in cardiovascular events. Important downsides of Alirocumab are the high cost and parenteral route of administration with a small percentage of injection site reactions. Though anti-drug antibody and reduced effectiveness were noted in studies with Bococizumab, which was a humanized antibody, immunogenicity was low for Alirocumab, which is a fully human antibody. Other adverse events noted were nasopharyngitis, flu-like illness, and occasional myalgia. Short-term studies have documented a good safety profile for the drug. Some long-term concerns about neurocognitive events and developing diabetes mellitus have been raised. A pooled analysis of 9 Odyssey phase 3 trials having nearly 1,000 patients with diabetes mellitus and atherosclerotic cardiovascular disease showed that the drug did not appear to affect glycemia over a 78 to 104 week period. Neurocognitive events were amnesia, memory impairment and confusional state, but these events were very rare. Here are the first set of references on Alirocumab. Here are the second set of references. Final set of references on Alirocumab are these. Cyanotic spells are episodes of worsening of cyanosis, also called hypercyanotic spells and TED spells for short, in infants with cyanotic congenital heart disease with low pulmonary blood flow. This group of cyanotic congenital heart diseases are known together as tetralogy of Fallot physiology. TED spells can also rarely occur in adults with tetralogy of Fallot. Cyanotic spells are associated with hypopnea and may lead to loss of consciousness and even hypoxic seizures if the episodes are prolonged. They can be precipitated by crying or other forms of exertion. A rare instance of refractory cyanotic spell in a patient with tetralogy of Fallot due to thrombus in right ventricular outflow tract has also been described. Thrombus occurred following intravenous iron sucrose therapy for iron deficiency, which is known to worsen hyperviscosity symptoms in tetralogy of Fallot. Proposed mechanism for cyanotic spells are increase in contractility of the infundibulum, enhancing obstruction and thereby right to left shunt and immature respiratory center causing hyperventilation bar hypoventilation, hypoxia, vicious cycle. Another mechanism suggested is mechanoreceptor stimulation from the right ventricle. Increased contractility of right ventricle due to catecholamines and decreased right ventricular volume can trigger reflex hyperventilation and peripheral vasodilatation and initiate a spell. Conventional treatment of cyanotic spells or TED spells is sedation with morphine, keeping in knee chest position, oxygen administration, hydration and intravenous propranolol. Knee chest position compresses the femoral arteries and veins, thereby enhancing the afterload and reducing return of desaturated blood from the lower limbs. Enhanced systemic afterload reduces right to left shunting across the ventricular septal defect and enhances the pulmonary blood flow. Use of intranasal midazolam in an emergency situation in an infant with difficult venous access, as the child was deeply cyanosed, crying and hypopneic, has been reported. Intravenous access could be easily obtained after termination of the spell. Another case in which cyanotic spell in tetralogy of Fallot could be relieved by intranasal fentanyl has also been reported. An interesting case reported manual auto-transfusion of blood from aorta to pulmonary artery for a refractory cyanotic spell occurring in the cardiac catheterization laboratory. Blalock Taussig shunt is useful in preventing cyanotic spells refractory to medical therapy when immediate surgical correction of the cyanotic congenital heart disease is not feasible. Cyanotic spells can occur due to dynamic left ventricular outflow tract obstruction in infants with detransposition of great arteries and intact ventricular septum. Worsening of outflow tract gradient with isopropanol and relief of obstruction with intravenous propranolol has been documented in these cases. First set of references on cyanotic spells. Second set of references on cyanotic spells. Eccentricity index is an echocardiographic index for separation of right ventricular volume and pressure overloads. Abnormal motion of the interventricular septum can occur in both right ventricular volume and pressure overloads. Ryan and associates have described a method to differentiate between the two. Two left ventricular minor axes are measured, one parallel to the interventricular septum and another perpendicular to it. Measurements are made both at end diastole and end systole. In normal subjects, the ratio between the two is equal to 1 at both end diastole and end systole. In patients with RV volume overload, the end systolic ratio is approximately 1 while that at end diastole is increased. In those with RV pressure overload, the eccentricity index was significantly greater than 1 at both end systole and end diastole. Thereby, eccentricity index of LV shape reflects the abnormal motion of the interventricular septum depending on the type of RV, whether systolic or diastolic overload. Eccentricity is reflected in the D-shaped LV cavity seen on echocardiography in severe pulmonary hypertension and right ventricular hypertrophy. This is an echo image from the parasternal short axis view. Normally, the LV cavity has a circular shape in this view. When there is RV volume overload, the interventricular septum bulges towards the LV and the LV cavity assumes a D shape in diastole. But as the LV contracts in systole, the pressure rises above that of RV and the LV assumes a circular shape. When there is severe pulmonary hypertension associated with elevated RV systolic pressures, the interventricular septum bulges into the LV in both systole and diastole so that LV cavity has a D shape throughout. In the echo image shown, right ventricular trabeculae are grossly hypertrophied, marked by the green arrows. Here is an important journal reference for the eccentricity index. Wilkins echocardiographic score for mitral stenosis. Wilkins echocardiographic score for mitral stenosis is useful for deciding whether the valve is suitable for balloon mitral valvotomy. The score was developed based on the first 22 patients who underwent balloon mitral valvotomy at their center. 4 parameters considered in Wilkins score are leaflet mobility, leaflet thickening, leaflet calcification, and subvalvular apparatus. Each parameter is graded 1 to 4 depending on the severity. Total score possible is 16. A score up to 8 is considered ideal for BMV. When the score is higher, the chance of significant mitral regurgitation as a complication of BMV is more likely. Regarding mobility, in grade 1, leaflet is highly mobile with only leaflet tip movement restricted. In grade 4, there is minimal or no movement. Other grades are in between. On the thickness aspect, leaflet thickness is near normal 4 to 5 mm in grade 1. In grade 4, there is considerable thickening of whole leaflet 8 to 10 mm or more. Grade 2 and 3 are in between. In grade 1 for calcification, there is only a single area of echo brightness. In grade 4, there is extensive brightness throughout most of the leaflet tissue. Intermediate grades are in between. Grade 1 for subvalvular thickening is just a single area of increased echo brightness. In grade 4, there is extensive thickening and shortening of all chordal structures down to the papillary muscles. Patterns in between are seen for other grades. Various other 2D echo-based scoring systems have been proposed later for the assessment of the mitral valve. These were Chen score, Reed score, Nobuyoshi score, and Cormier score. With the onset of 3D echocardiography, scores based on 3D echo has also been proposed. 3D grading might overcome the difficulty in differentiating between calcification and nodular fibrosis. Here are the first set of references on echo scoring in mitral stenosis. Second set of references on echo scoring in mitral stenosis is here. Third set of references. Head-up tilt test known as HUTT or tilt table test is commonly done for the evaluation of neurocardiogenic syncope, example vasovagal syncope. Various protocols are followed in different centers. One protocol is as follows. The subject is strapped to the tilt table after venous and arterial access is obtained. Radial arterial access is used for continuous blood pressure monitoring as non-invasive recordings are often inaccurate and difficult to make at the time of syncope. But the radial cannulation is invasive and may not be acceptable for all. Moreover, the pain can induce syncope in those prone for it. Beat-to-beat non-invasive blood pressure monitoring with finger cuff is useful but often not available. Infusion pump is also set up to give isoprenalin infusion if required. Resuscitation tray and personnel are at hand during the test. ECG, pulse oximetry and invasive blood pressure are monitored throughout, and the hemodynamic response is also charted. Initial supine phase is for 30 minutes, which is followed by a tilt phase of 20 minutes at an angle of 70 degrees. If syncope does not occur during this period, the table is brought to the supine position for a period of 10 minutes. After that, isopranoline infusion is started at a rate of 1 microgram per minute. The drip is run for 10 minutes with the table tilted at 80 degrees. Still, if syncope does not occur within 10 minutes, the table is brought back to the supine position for 10 minutes. The test is repeated at 3 and 5 micrograms per minute of isopranoline with intervening 10 minutes of supine position if needed. If there is no syncope, the test is considered negative. Syncope can occur at any of the above stages, either with bradycardia, hypotension, or both. The first one is called cardioinhibitory, second one vasodepressor, and the third mixed variety. A change in the pattern of HUTT response with age has been described, with cardioinhibitory response becoming less common with advancing age. This difference is thought to be due to the higher vagal activity in younger age, promoting more of cardioinhibitory responses. Vasovagal syncope international study had classified syncope into VASUS 1 mixed, VASUS 2A and 2B cardioinhibitory, and VASUS 3 vasodepressive varieties depending on the result of the head-up tilt test. Further modifications were suggested by Brignol M and associates. Prognostic significance of unduly prolonged asystole of 30 or more seconds during head-up tilt has been studied by Carvalho and associates. In their study of 2,247 patients, 149 had asystole, of which 11 had 30 or more seconds of asystole. The longest pause recorded in their study was 63 seconds. None of these patients had received a pacemaker in this retrospective study. 4 patients had recurrence of syncope after a follow-up period which ranged from 30 to 76 months. 1 had scalp laceration related to the syncope, and no patient died in this study. 9 different hemodynamic patterns in response to head-up tilt test in pediatric patients have been described by Osgood and associates after assessment of 400 pediatric patients. These responses include postural orthostatic tachycardia syndrome in addition to the usual head-up tilt test responses. There are some authors who feel that head-up tilt test is not useful and should be abolished. Indications for HUTT in syncope include 1. Recurrent syncope or pre-syncope, 2. High-risk patients with single syncopal episode, example serious injury with syncope, syncope while driving. 3. No other cause for symptoms by history, examination or cardiovascular and neurological workup. 4. Elderly patients with recurrent unexplained falls. 5. For the differential diagnosis of convulsive syncope, orthostatic hypotension, postural orthostatic tachycardia syndrome, psychogenic syncope, hyperventilation syncope, and carotid sinus hypersensitivity. Relative contraindications for HUTT include 1. Severe left ventricular outflow obstruction, 2. Critical mitral stenosis, 3. Severe proximal coronary artery disease, and 4. Severe cerebrovascular disease. First set of references on HUTT. Second set of references on head-up tilt test. In this lecture, we will review the aims, benefits, phases, and potential risks of a cardiac rehabilitation program. The primary aim of cardiac rehabilitation is to enable the patient to regain full physical, psychological, and social status after a cardiac event. Cardiac rehab can optimize the long-term prognosis by secondary prevention. The following patient groups may benefit by cardiac rehab programs. 1. Following an acute cardiac event. 2. Awaiting or post-revascularization. 3. Stable angina. 4. Stable heart failure. 5. After valve surgery. 6. After heart transplantation. 7. After insertion of an implantable cardioverter defibrillator or ICD. Myocardial oxygen consumption depends on the double product. Double product is equal to heart rate multiplied by systolic blood pressure. Double product determines the myocardial workload. Rise in heart rate and systolic blood pressure is determined by the oxygen consumption expressed as a percentage of maximum oxygen consumption rather than the absolute value of VO2. VO2 max increases with exercise training. Hence, the rise in heart rate and systolic blood pressure and consequently the myocardial oxygen consumption for a given level of activity decreases as exercise training program progresses. MET or metabolic equivalent is the basal metabolic oxygen consumption. 1 MET is equal to 3.5 ml oxygen per kg per minute. Cardiac output can increase almost 6 times with maximal exercise. Oxygen extraction from arterial blood can increase almost 3 times with peak exercise. Hence, oxygen consumption can increase about 18 times, that is known as VO2 max. But in case of coronary circulation, oxygen extraction is maximum even at rest. So that increase in oxygen supply can occur only by an increase in flow. A person with maximum exercise capacity of less than 2 METs will be in class 4. Those with an exercise capacity of 2 to 5 METs will be in class 3, and those with a capacity between 5 to 7 METs will be in functional class 2. If a person has more than 7 METs of exercise capacity, the functional class will be 1. Benefits from a cardiac rehab program will include a reduction in angina, blood pressure, anxiety and depression, as well as hospital admissions. There is an improvement in the lipid profile, functional capacity, better compliance with lifestyle modification, increase in the level of confidence, and earlier return to work and leisure activities. A comprehensive cardiac rehab program can include proper medications for secondary prevention and symptom limitation, graded exercise programs, advice on healthy eating, including participation in weight loss support groups, relaxation by stress management, general information on the disease process, and a training on cardiopulmonary resuscitation for the relatives. Exercise programs do carry risks of worsening of ischemia, left ventricular dysfunction, and potential for life-threatening arrhythmias. Hence, a proper risk stratification is needed prior to initiation of the exercise component of cardiac rehab. Exercise component of the cardiac rehab should be deferred in case of unstable angina, resting BP above 200 by 110, significant drop in BP during exercise, resting heart rate more than 100 beats per minute, uncontrolled arrhythmias, unstable heart failure, unstable or uncontrolled diabetes mellitus, and febrile illness. The program can be resumed after stabilization of these situations. Discussion on Annulus Paradoxus and Annulus Reversus on tissue Doppler in constrictive pericarditis. The term Annulus Paradoxus was proposed by Ha and Associates to indicate the inverse correlation of E by E prime to pulmonary capillary wedge pressure on tissue Doppler evaluation in constrictive pericarditis. Usually, a positive correlation is found in patients with primary myocardial disease between E by E prime and PCWP. In their study of 10 patients, E prime was not elevated despite high left ventricular filling pressures. Hence, E by E prime was low with a mean 9 and it was less than 15 in 9 of their 10 patients. Another study of 130 surgically confirmed patients with constrictive pericarditis from Mayo Clinic reported similar findings. They noted significantly lower E by E prime ratios at medial mitral annulus in patients with constrictive pericarditis compared with patients without constrictive pericarditis, mean 5.8 versus 16.1. The authors acknowledged the preserved or accentuated E prime velocity in constrictive pericarditis, leading to the lower than expected E by E prime in the setting of increased left ventricular filling pressure as Annulus Paradoxus. But Alirocumab and colleagues challenged the concept of Annulus Paradoxus in constrictive pericarditis while reporting their study of 49 surgically confirmed constrictive pericarditis. Their patients underwent right heart study with measurement of PCWP after an echocardiographic evaluation. They could not find any correlation between septal, lateral or mean E by E prime and PCWP in constrictive pericarditis. In fact, they suggested revisiting the phenomenon of Annulus paradoxus in constrictive pericarditis. Chabra and colleagues, in a comment to this article, pointed out that though the larger study from Mayo Clinic strongly favor the presence of Annulus paradoxus, direct correlation of E by E prime ratio with left-sided filling pressures was not performed. They called for a restudy of this relation in future large-sized controlled prospective investigation. Hughes and colleagues reported on tissue Doppler study of mitral annular velocities in 14 patients with constrictive pericarditis, 10 with restrictive cardiomyopathy and 17 normal subjects. They noted that in controls, mitral lateral annular E prime velocity was 25% higher than medial E prime velocity. In constrictive pericarditis, the averaged lateral E prime velocity was 2% lower than medial E prime velocity. They termed this reversal of lateral and medial E prime velocities compared to normal subjects as Annulus Reversus. Patil and colleagues in their study of 23 patients who underwent pericardiectomy for constrictive pericarditis also refers to this Annulus Reversus. They documented that the ratio of medial to lateral mitral annular velocities reduced from 1.08 to 0.87 after pericardiectomy. But Annulus Reversus was found to persist in 6 responders, reflecting 50% reduction in its incidence after pericardiectomy. The lower lateral mitral annular velocity in constrictive pericarditis is thought to be due to the tethering by thickened pericardium. Negative radionuclide perfusion study due to similar degree of stenosis in all the 3 major coronaries is known as balanced myocardial ischemia. This is because the radionuclide used for perfusion study will have equal uptake in all the 3 regions of myocardium. In most cases, this is picked up by the treadmill ECG, usually done along with stress myocardial perfusion imaging. ECG findings of myocardial ischemia does not depend on the relative perfusion in the coronary tree. Ischemic changes will be noted in treadmill ECG even when nuclear perfusion study shows false negative due to balanced myocardial ischemia. In one published report, adenosine technetium 99 SOSTA-MB scan showed no rusting or stress-induced perfusion defects in a person with stable exertional chest pain. But ST segment depression was noted on the ECG. Coronary CT angiogram showed severe calcified ostial left main lesion, which was further confirmed by invasive coronary angiography. The patient underwent successful coronary artery bypass surgery. In another case report, there was triple vessel coronary artery disease including 95% distal left main stenosis with a markedly positive stress ECG and a negative SPECT 99 SOSTA-MB scintigraphy. This patient also underwent successful coronary artery bypass surgery. Other potential causes of false negative nuclear perfusion studies are lesions in the left circumflex coronary artery, use of anti-anginal agents prior to the test, and low levels of exercise leading to low myocardial oxygen demand. Caffeine use can interfere with dipyridamole stress nuclear perfusion imaging due to drug interaction. As a corollary, balancing of electrical vectors in opposite directions have been invoked to explain false negative exercise treadmill ECGs in patients with multivessel coronary artery disease. Discussion on chat stop for initial management of cardiac amyloidosis. Targeted therapeutic measures depend on the type of amyloidosis, whether it is light chain or transthyretin type. Chat stop is the mnemonic for the initial steps in the management of cardiac amyloidosis. C. Conduction and rhythm disorder prevention. H. High heart rate maintenance. A. Anticoagulation. D. Diuretics. Stop beta receptor and calcium channel blockers, digoxin and renin-angiotensin aldosterone inhibitors. Preload reserve is limited in cardiac amyloidosis due to severe diastolic dysfunction. Hence, the only way to increase the cardiac output is by the heart rate reserve, and hence it should not be cut down by beta blockade or calcium channel blockade. Renin-angiotensin aldosterone inhibitors carry the risk of severe hypotension, especially in the presence of autonomic nervous system involvement. Cautious use of diuretics is useful to reduce the congestion of heart failure, but excessive diuretic usage can lead to low cardiac output. Amiodarone can be used as an antiarrhythmic agent if needed. Anticoagulation may be needed in case of supraventricular arrhythmia like atrial fibrillation, previous history of systemic embolism, or intracardiac thrombi. There is a higher chance of thromboembolism in cardiac amyloidosis even in sinus rhythm. Pacemaker implantation may be needed in some cases of cardiac amyloidosis. Chordal preservation is important in maintaining LV function after surgery. Severe calcification and subvalvular fibrosis make chordal preservation during surgery difficult. The concept of chordal preservation during mitral valve replacement was introduced by Lillehay and associates as early as 1964 to prevent the postoperative low output syndrome. Experimental evidence in support of chordal preservation was provided by canine studies of David and colleagues. They demonstrated deterioration of LV function in the absence of chordal preservation. Chordal preservation maintains the annular ventricular continuity and prevents progressive dilatation of the left ventricle, which can occur in its absence. Many operators preserve the posterior leaflet and chordae while excising the anterior leaflet and chordae. This is because of the possibility of redundant anterior chordal tissue obstructing the left ventricular outflow tract. Preservation of both chordal systems may also necessitate downsizing of the mitral prosthesis, but a randomized trial of partial versus complete chordal preservation suggested that the results are better with complete than partial chordal preservation. Chowdhury and associates have reported on chordal preservation in the setting of rheumatic heart disease. Of their 451 patients, 70 had complete excision of the mitral subvalvular apparatus. 124 patients had preservation of the posterior chordopapillary structures, while 257 had total chordal papillary preservation. They demonstrated that left ventricular ejection fraction and fractional shortening declined over time in the group without chordal preservation. Total chordal preservation group fared better than the partial chordal preservation group and the group without chordal preservation. Important factors to be considered while preserving the chordae are: 1. Prevention of left ventricular outflow tract obstruction due to systolic anterior motion of the preserved portion of the anterior mitral leaflet. 2. Prevention of interference with prosthetic valve function. 3. Ensure an adequately sized prosthesis to prevent postoperative patient prosthesis mismatch. Cone procedure for Ebstein's anomaly of tricuspid valve constructs a funnel-like valve using the native leaflets. This avoids the problems associated with artificial valves, including bioprosthetic valves, especially in children. In one study, cone procedure group had 85% reduction in tricuspid regurgitation compared to 56% in the conventional group at discharge from hospital. The cone procedure involves detachment of tricuspid leaflets, division of chordae, plication of the tricuspid annulus, rotation of leaflets, and final reinsertion of the leaflets in the modified tricuspid valve annulus. Since cone procedure has become an effective hemodynamic intervention for Ebstein's anomaly, late mortality due to arrhythmias assume more importance. Periprocedural electrophysiological study and ablation of potential arrhythmic circuits have been suggested as a preventive strategy. This aggressive protocol documented significant electrophysiological findings in 69%, including 8 patients in whom there was no prior suspicion of arrhythmia. 17 of these patients underwent catheter ablation, while the remainder had intraoperative interventions. The strategy could prevent sudden death in those treated with this protocol. Real-time intraoperative 3D transesophageal echocardiographic guidance for cone procedure has been used successfully as in case of mitral valve repair. Coronary steal is diversion of coronary flow from one artery to another. Coronary steal can be either from one coronary territory to another or from a coronary territory to a non-coronary territory. Different such scenarios can be found in literature. Abnormal stress test due to large anomalous vessels supplying a large left atrial myxoma producing coronary steal has been reported. Symptoms and abnormal stress response resolved after resection of the tumor and ligation of the abnormal vessels. Another situation is coronary steal into a coronary cameral fistula connecting a coronary artery branch to the left ventricle. Rupture of a coronary artery aneurysm into the right atrium in a patient with systemic lupus erythematosus and sepsis resulted in inferior valve myocardial infarction due to coronary steal. Angina and positive stress test occurred in a patient with a fistula connecting left anterior descending coronary artery to left superior pulmonary vein. Coronary steal and ischemia can occur due to a patent side branch in left internal mammary artery to coronary artery bypass graft. Coil embolization of the Lima side branch produced relief of coronary steal and ischemia. Multiple coronary microfistulae into the ventricles due to persistent Thebesian veins is another rare cause of coronary steal. These cases are not amenable to any surgical measures but respond to usual anti-anginal medications other than coronary vasodilators. Coronary vasodilators can theoretically worsen the coronary steal phenomenon. Coronary steal can occur in post-CABG patients with the Lima graft if the subclavian gets occluded. A post-CABG patient who had Lima to LAD graft and bilateral carotid artery subclavian graft occlusion presented with non-ST elevation myocardial infarction. The patient was successfully treated with endovascular procedures in the cardiac cath lab.